Welcome back. I'm excited to begin our first listening session. Chinny and the PCDT helped us level set with our extremely helpful background information. Now we've invited 4 outside experts to give short presentations on best practices for total cost of care models based on their experience. You can find their full biographies on the ASPE PTAC website. Their slides will be posted after the public meeting as well on the website. After all 4 have presented, our committee members will have plenty of time to ask questions. Presenting first, we have Dr. Debbie Zimmerman, who is the Corporate Chief Medical Officer from Lumeris. Please begin, Debbie, and welcome.
Thank you. So first slide, please. I'm going to talk today about a total cost of care model in a Medicare Advantage population. I don't see my slides. Am I? Maybe I'm.
I think they're putting them up. They're just.
Okay, great. Well, it's okay. I'll do the introduction and we'll be good. So I'm going to talk about a Medicare Advantage population. One of my roles is as Chief Medical Officer of Essence Healthcare, which is a Medicare Advantage health plan in Missouri and Illinois. It was started by physicians. So first slide would be great. It was started by physicians with the idea that physicians and health plans working together can really provide better care to Medicare beneficiaries. And I think we've been able to prove that over time. So I'm going to talk a little bit about that model, and it is really based on partnering with physicians around managing total cost of care, of course, balanced with quality and access. So this first slide is like this is the take-home message, right? These are the learnings. On the right-hand side are our outcomes. So just to say, okay, have we been able to achieve the results that we're looking for? And we think of it in terms of the AAA plus 1, right? So reducing per capita costs in our population when we compare it to traditional Medicare, risk adjusted for age, gender, geography, risk, chronic conditions, et cetera. We were able to lower costs about 26%. I'm going to talk a little bit about how that happened. Quality. Well, we've been 4.5 stars now, and those of you that know star ratings, not a perfect measure of quality, but it's a reasonable one. Measures quality of care and quality of service, which is the way we think about it, right? We're actually a 5-star plan this year, so very excited about that. We've got the consumer experience 5-star and CAP survey and a member satisfaction survey, very low disenrollment. So evidence of great consumer experience, and our providers are very much aligned with us. So given those outcomes, what is it that drives those outcomes? And I know we're focusing on that first one around total cost of care. So what did we think drove those results? So we did a study. The way our plan works is every physician is in a medical group, because in order to have total cost of care incentives, you really need an actuarially credible population. So you have to aggregate lives. In addition, one of our drivers we'll talk about is that you sort of need that learning environment, your mentoring environment. You need that in order to perform well, right? So we looked at each of these groups and we said, what were the drivers of performance? And we used total cost of care as the outcome. And these were the 6 drivers, and these 6 drivers actually predicted 90% of performance because there's large variation between the groups we looked at. I'm going to go through each of these. That's really what I'm going to talk about today. So not surprising, first 2 aligned incentives. First one is that contract between the payer and the provider organization. Second is, how does it trickle down to the individual physician? How am I incentivized? Third one, which is the biggest lift, is actually changing the way care is delivered. And we spend a lot of our time thinking about that. And that is the heaviest lift. We think core to that is the delivery of accountable primary care. We think that's the biggest lift, is changing the way primary care is provided, but the rest of the delivery system needs to change as well. Enterprise engagement means there needs to be some commitment, right? If I only have a couple of my patients that are in a value-based care, total cost of care contract and the rest are in fee-for-service, I'm not going to make the changes I need to make in my practice. As a health system, I'm not going to make the changes, the investments that need to happen if I don't have that commitment. Leadership and governance, really, really key for all the physicians in the group, right? Getting people to change behavior is very hard. Getting physicians to change behavior is potentially harder. You really need great leadership. And then lastly, the right information. So I'm really going to talk about these things. These are what I think is core to total cost of care management. So next slide. I already described on the left-hand side our model. Our model is every patient is accountable primary care, or accountable primary care is in a group, and every group is in a value-based contract. All of them, 100%, have total cost of care incentives balanced with quality and access. Complete transparency. The payer and the physician groups are totally aligned. Everything is included in that contract, and they understand exactly how it works. And we invest, and we're going to talk a little bit more about that. So next slide. Great example of what does it mean to manage total cost of care. We spend a lot of time saying, what's the difference between an unmanaged population and a managed population? Because the more we know about that, the more we know what programs to develop, the more we know where to focus. This basically says risk score on the x-axis, cost on the y-axis, compared to traditional Medicare. Lower costs for high-risk patients. We all know that. Spend a lot of time. Complex case management, end of life, reducing readmissions. We know that. The thing that warms my heart but really speaks to population health is you have to invest in the low-risk patients. Significant increase in investment and services in those lower risk patients. That's population health, right? Everybody. We've never seen a medical group be successful in total cost of care in Medicare if they don't see at least 95% of their patients once a year. Just doesn't work. Next slide talks again about how this 26% reduction occurs, but it's not an overall equitable reduction. Decrease inpatient, increase outpatient, decrease specialty, increase primary care. It really does change the distribution of costs. Next slide, please. Talk really quickly. You'll be able to get a chance to read these slides, and you can certainly ask questions, but I'm going to talk quickly now a little bit about each of these different drivers. On the left-hand side, the aligned incentives between payers and physicians. I think we've talked about it. Total cost of care, complete transparency, making sure that the level of risk meets the providers where they are, putting a provider group at full risk and having them pay the payer back just is not a sustainable model. And then really investing in helping them perform is really key. Again, balancing those total cost of care incentives with quality and access is also really, really important. And then on the right side, how it trickles down. We spend a lot of our time working with physician groups. It's out of our control how they pay their docs, but we spend a lot of time working with them on how to put in place a really fair and equitable compensation model that incentivizes, shared learning, shared accountability, improvement of everybody, right? You don't just want to reward those that are high performing. You want to figure out how to take, we like to call them high volume, high opportunity providers, and how to mentor them and improve their performance. So a mix of we're a group, we're sharing together on how we perform. That makes us accountable to each other, but also I got to have some skin in the game as an individual physician, right? So we spend a lot of time talking about that with our groups. Next slide. This one could be a whole hour in and of itself, and 10 minutes is tough to fit it in. This is really how do we change the delivery of primary care, and how do you change the way care is delivered? We spend a lot of time, yes, care management programs, those described on the right, are really important. In my experience, if you don't change the way care is provided, these care management programs will not get you to that 26% reduction in overall cost. That physician and that patient, that APP and that patient, that team and that patient. You have to change the way that care is delivered, and you have to change the way, obviously, that patient also is caring for themselves. So really, really important. We spend a lot of time, we've defined what we think the hundreds and hundreds and hundreds of activities are that are necessary to deliver accountable primary care, what the attributes are to deliver accountable primary care, and we work very hard with groups to make this change. Next slide. This is really just a description of some of the investments we make. We put feet on the street. We put people in the offices with one purpose and one purpose only, and that's to help them change their practice to produce those outcomes that we talked about earlier. And that's everything from the way they schedule to, pre-visit planning, daily huddles, how to actually work with your team. So everybody practices at the top of their license. How to work with APPs and make sure that your patients are getting the best care possible. We have something called Rapid Practice Transformation, where we work with offices to help change the way they practice, and we even have a boot camp for providers. Oh, that's my time. Next slide. had my timer on. So okay, I cannot emphasize leadership and organization. Really key. Already said key. We invest in these. You need mentors. Next slide. This might be my last one. Oh, you can skip this one. But it's really important that you have the right structure and that data does trickle down. And the last one is having the right information. I need to know how I'm performing at the population level, because if you ask me, I think I'm doing great. I need to see where my opportunities are as a system and as an individual physician. And then when I have that patient or individual in front of me, I need to know about that individual. What are their gaps in care? What is their care across the continuum? Have they been taking their medications? Have they been in the emergency room? What specialists have they seen? And we believe need to have insight into the cost of care. How can we hold physicians, providers accountable for the cost of care if they don't have insight into the cost of care? So in our model, they have that ability to drill down to the claim level to see the cost of care. I think that's my last slide.
Thank you, Dr. Zimmerman. Great presentation. We're saving all questions from the committee until the end of all presentations. So we'll hold our questions for now. So next we have Dr. David Kendrick, who is the Principal Investigator and CEO of MyHealth Access Network. Dr. Kendrick, please begin.
Thank you for inviting me to give this presentation today. I'm the CEO of MyHealth Access Network, the Health Information Exchange for Oklahoma. I also chair the Department of Medical Informatics, and just awaiting my slides here. Other disclosures, immediate past chair of the Board of Directors for NCQA, and also, next slide, and also on the board of something called the Patient Centered Data Home. Next slide, please. Next slide. So our experience with the models from CMMI is pretty extensive. We were originally in CPC Classic, CPC Plus, AHC as well, and now entering into primary care first. And so these are hopefully practical lessons learned from on-the-ground work, supporting, really picking up where Dr. Zimmerman's last slide ended, which was with information technology and infrastructure. Next slide, please. So there are 5 categories of lessons learned I want to convey to you today with some sub-bullets, and I'll try to get through them all. Next slide. So the first was multi-payer models. We've really enjoyed those, and CPC Classic. Uh-oh. Not sure where my... All right, so back one, please. Thank you. So in CPC Classic, of course, we had multiple payers, and one of Dr. Zimmerman's principles, most of the patients in every participating practice were in the model, and that also brought lots of infrastructure to bear. However, it also created a burden for community convening and governance to help those private commercial payers work together with one of the largest federal government agencies to do this work. Next slide. On the model execution side, so now we're into the weeds of what technical changes we were able to make. First, the scope of data available to providers is critical. Next slide. And we always talk about claims data being a mile wide but only an inch deep, and the data in each clinic being a mile deep but only an inch wide. And so real patient data looks like this. And this is the role of our organization as serving as a health data utility to make sure that the full picture of each patient's care is available. And of course, the sicker the patient, the more fragmented their data. And that's really a theme of our work. Next slide. And then, of course, 20% of commercial lives change payers every year, which essentially is a death and birth event from the perspective of that payer with data. Next slide, please. We quantify that data rigorously in Oklahoma, that fragmentation rigorously in Oklahoma. We show about 70% of every patient encounter. 70% of every patient seen has data in more than one clinical location. That's actually over 90% now that we've updated it. And this is corroborated by data from MyFam that showed that the average PCP has to coordinate care with 225 other providers in 117 other organizations, which makes this infrastructure critical. Next slide. And you add one chronic disease, that number goes up. Two chronic diseases is virtually 100% fragmentation. Next slide, please. Even when we take large EHR vendors, including Epic and Cerner, that fragmentation is about the same 70-30 split, and it only grows. That fragmentation only grows. Next slide. This is our network in Oklahoma. We have more than 1,400 locations connected with live flowing clinical data, as well as claims and other types of social needs data. More than 110,000 clinical encounters a day statewide. And if you can see or read the bottom, it's more than just hospitals and clinics. We're talking about mental health facilities, pharmacies, long-term care, urgent care, and even social service agencies. And this is critical because just looking at EHR data doesn't get this job done. Next slide, please. However, the data in MyHealth looks like this. These are patients who've received care in Oklahoma at some point in the last 2 or 3 years, which means these patients are moving around, and we have to have a national look at this data in order to provide comprehensive care. Next slide, please. We provide patients and all providers with a common look at a patient chart. That's a summarized version that's cleaned up and organized across all of those sources of data, clinical data. Next slide, please. The next concept, aside from data, is that patient attribution is a difficult concept for providers, and it's not accounted for usually in the internal analytics of the EHR. Next slide, please. So what happens here is my EHR tells me about patients I've seen in the last 12 months, but Blue Cross thinks my patients are attributed via a different set of logic, and Medicare's models each have their own models, and Medicaid and each commercial payer assigns patients to me differently. So you can see that very quickly, providers have a majority potentially of the patients they're obligated or accountable for outside of their line of sight. And by line of sight, I mean they're not seeing them automatically in their quality measures. They're not seeing them in their denominators. Next slide, please. Alerting and sentinel events is critical. Next slide, please. So this is care fragmentation alerting, somewhat like an advanced version of ADT alerting. Tells me of all my patients seen or touched in the last 24 hours and what activity that was, no matter where it was. Next slide. Next click, please. 30-day readmission monitoring tells me immediately when my patient registers for care somewhere for an impending 30-day readmission, whether it's an ER, an urgent care, etc. Next slide, please. Performance measurement and reporting. Our lesson learned here is that community-wide quality measurement is required to assess true performance results. Next slide. So MyHealth serves as a health information exchange and a health data utility as a trusted third party for measurement. We sit in between the payer and the provider, and indeed in between the social service agencies as well. And then that capacity serve as both the health information exchange and an all payer claims database. We're able to take the most relevant and recent data from multiple sources to calculate the quality measure. And here's why that's important. Next slide, please. So recall this diagram. These same patients, if they're all have diabetes, they're going to have multiple hemoglobin A1Cs taken over the course of a year in all the different clinics where they work, where they are seen. Next click, please. And as you can see, each of those EHRs are going to report a completely different set of quality results based on the hemoglobin A1C that they can see. It's the classic blind men and the camel problem. And they're each going to describe different components of that animal. And so what the problem is here, I've got 4 patients, I've got 11 different measures of performance. Which one is true? Well, the fact is none of them are true. Next click, please. However, that's the state of the art today. So if you take that table, turn it on its side, that's the upper left chart. You can't add that up to a population number. You can't tell me at the belly button level what performance is for this population. Whereas in a health information exchange, a health data utility, we take the most recent result for each patient and uniquely calculate that patient's status. Next click. And so in Oklahoma, we know everybody who's in control, out of control, or excluded from a measure, and then we can use our attribution logic or the attribution logic provided by each of these stakeholders to determine what the performance is. And you can see each of those calculations of performance on the right are very easy to make once you apply the attribution logic. And this is the way we handle quality measures. You can see there's also geographic regions there. That's public health, basically, and even employers engaged. Next click. Other things about performance measurement, one of the real downsides to total cost of care models is this incentive it creates to fire the sickest patients and avoid having sick patients on your panel. And so I think there's an opportunity here to incent providers to take on the sickest patients if we start to measure and reward deltas in performance. Counts of patients that improve versus counts of patients that did not improve, and start to apply that approach to measurement, at least for a component of the model. Should use common metrics across all models. I think that goes without saying. And more rapid interim and final results so that we don't have to end a model, lose all the infrastructure, and then scramble to rebuild it. We really need more real-time quality measurement and so on, and that's possible with this infrastructure. So next click, some specific model feedback. Of course, we have our cost models that we can report on by service line, and this is across all payers. That's critical for practices to understand rather than to study each payer's proprietary reports. Next click. So the next set of items are about model-specific results. So CPC and CPC Plus, we found, next click, effective care coordination requires health information exchange, and we also submit electronic referrals. We studied this extensively starting in 2007, and this was really the process of making referrals of patients across a community, especially where patient referrals were happening outside of an organization. We found thousands of referrals that were simply dropped, and everybody's aware that at the end of the year, staff are on phones calling clinics trying to close loops on referrals simply to meet that metric. That's artificial in our opinion. Next click. So we studied it, found that there were about 25 unique states referral could be in, and if you had an electronic hub in the middle that could monitor these statuses. Next click. You could have a workflow like this wherein the sending and receiving provider, whether they're PCP or specialist, doesn't matter, but sending and receiving can coordinate all the steps of that referral and even feed that back into the electronic health record system. Next click. And we were able to demonstrate significantly improved rates of loop closure happening behind the scenes with the machines handling tracking of the results of that rather than labor and intensive phone calls. Next click. The next item here was to leverage that infrastructure to do electronic consultations to enable specialists as consultants to triage the cases, to make sure they needed to see them before they saw them. This becomes critically important to practices when they take on risk. And what we were able to demonstrate using this workflow, next click, was a significant cost reduction within each patient from before to after their consultation, as well as across all populations, those who received the electronic consult versus those that did not, for $130 PM cost savings comparing those two populations. Next click. We also were part of the HC model. Next click. And we were actually able to put in place a model that could reduce provider burden for screening social determinants of health. So this shows that just like clinical data is highly fragmented, so too is social services, social determinants data. And you can see these, if a patient needs a food pantry, they are very likely to need housing or transportation or other social services. So we set about trying to defragment this data as well. Next click. We put in place a mobile screening system triggered by what we uniquely knew as a health information exchange. That is the patient registration for care, delivered a screening to the patient's phone they complete while in the waiting room in under 3 to 4 minutes. They complete that screening. We score it immediately. Next click. Next click, please. Then if they're positive for a social need, we have a database of almost 5,000 community services across the state of Oklahoma, tailored, and we're able to deliver back, next click, to the patient's phone, a tailored referral to meet their needs that's closest to them or nearest where they're sitting physically at that time. And they can simply click a link and be talking to the food pantry or the housing service while they're still waiting to be seen in the emergency room or the clinic. We also feed this data back into the practices so they're aware of this information. Next click. So we've now offered more than 2.8 million actually offers for social needs screening. We've had over 500,000 responses, and we've dealt with 100,000 social needs at this point and referred them for services. This scaled very well and turned out to be a COVID-proof process as people had their phones even during telemedicine. Next click. And so we can tell by very granularly where social needs are by sites of care. Next click. By payer type as well. And we show, of course, even commercially insured patients have a 17% rate of social needs in our community. And this is of great interest to those populations. Next click. So we've demonstrated we can work with clinical data, claims data, and now social determinants of health data. We put the three together into this virtuous cycle of improvement. Our biggest challenge now is that these models are ending, and so our social needs screening program has nowhere to go. It's ending. We're working on sustainability, but all the indicators are that it's going to be a positive result for the model, but at this time, there is no follow-on model to extend it. Same thing with CPC Plus. Data aggregation ended for us in 2021, so we've given up the ability to work with that claims data, unfortunately. However, when we put the three together, we've been able to demonstrate, next click please, maximal impact. So for example, when we compared practices in CPC Plus who also participated in AHC and did the social determinants of health screening, you can see the blue line there, significantly different cost trend for those practices. Next click. And utilization of emergency rooms among the practices who participated in the social determinants of health screening as well as CPC Plus. Next click. So the sweet spot is putting all of these together. And next click. You can see the three on the left, the daily visits of my patients. On the upper right, the total cost of care. The middle on the right is the trend of cost spend, and the lower right is the trend of this patient's social determinants of health needs, social needs. And then I'll start to wrap it up. Next click. Different patient, different cost trend, different emphasis. Next click. And so next click. What we were able to show was that dwell time was one of the most important things as we moved from CPC Classic to CPC Plus. Those practices in red moved through CPC Classic into CPC Plus and had a different start time. So I became convinced that the dwell time in these models was one of the most important interventions, and over time, everyone could achieve these results if they just had enough exposure to it. Next click. This was the same information, but for cost trend. Next click. And then I'll close. So next click. So one of the things that we've observed in our community is we spent 10 years building this infrastructure hand in hand with these CMMI models, using them as the direction to build this infrastructure, and really believe that this serves as a great laboratory for rapid startup of these models, quick evaluation, and the ability to iterate quickly on those results, and then finally a channel through which to deploy those results. Thank you guys for your time, and I'll be ready for any questions when they come along.
Thank you, Dr. Kendrick. So now we have Ms. Yi-Lin Lin, a healthcare actuary and financial strategist who joins us from the Terry Group. Please go ahead.
Hi, good morning. Good morning. Thank you for having me today. My presentation is going to be a little bit different. It's going to be pretty high level. I know numbers sometimes scare people. We're going to try to boil it down to a couple of different the sort of fundamental principles that we've learned as we've worked with our clients. I am a consulting actuary, and our clients tend to be hospital systems, physician groups, also payers, and employer groups. And so we've seen this sort of thing from a variety of different perspectives within the industry. So next slide, please. So what I'd like to concentrate on today are three fundamental principles that we've noticed that we think that will really move the needle if people sort of pay attention to it. You know, what we don't want to do is be moving chairs on the deck of the Titanic, right? We really want to be steering the ship to try to avoid that iceberg. And so a lot of things we feel like right now are geared towards trying to just do short-term benefits and really lose kind of the long-term focus of trying to improve the health of the entire country and our populations and bend that cost curve for the long term. So the first thing I'm going to talk about is the use of historical data and what I feel is an over-reliance on it. Data is really important, don't get me wrong, but there is just this crutch that we're using that really says that we are trying to look in the past and expect that that past is going to be totally indicative of the future, and I don't think that's actually true. The second thing I'm going to talk about is this one-year time horizon. So everything in the industry right now, the way that people get paid, all the quality measures, everything is on a one-year time horizon, but we all know that healthcare is not a one-year time horizon, and so there's this mismatch that's going on there. And then the third thing I'm going to talk about is the use of risk scoring. So risk scoring or risk adjustment is that mechanism where we try to assign a value to somebody's health status, and then we actually use that for a variety of purposes within the industry. So these are, again, only three fundamental principles. There's obviously a lot of other things that are very important, but we're going to concentrate on these three today from an actuarial perspective. So next slide, please. So using historical data, as I said, what I believe is that there is an over-reliance on historical data. So my experience with working with our payer clients and our provider clients is that they ingest all this data, which is very valuable, but then they set measures for next year based on those historical measures. And they might say something like, well, and I'm going to use some really round, non-realistic numbers, but just easy to follow. So my cost per patient per month is $100 from last year from my data. And let's try to hold the trend so that next year the cost is no more than $105 per month per patient. And so that ends up getting into contracts, value-based contracts, where that measure, that 105 is the target. Well, that's an anchor to the past. That's not really a direction for the future. Is $105 really the right amount? Or is the right amount really $85? Or should be $125 if we increase a bunch of preventative services and things that are not being used appropriately? So that trend number anchoring on historical data, I think, is misleading in the sense that we really need to find something in the future that says what we really believe that utilization of the healthcare services and costs in the future should be some dollar amount, and then put in a plan together to get from point A, where we are now, to where we think we should be in the future, not always anchoring to where we are or where we have been. The second thing that I've noticed that happens is that $105 target amount that's for next year really penalizes organizations that do really well in total cost of care arrangements. So what happens is, everybody starts, and let's say we're going to start everybody at that $100 historical data, and next year we're going to have you target 105. Okay, so provider system A meets that 105. Well, great. The mechanism for all these contracts is that, well, now your experience under our plan is $105. So next year we're going to increase that another 5%. So your base is now $105. But provider system B does better. They beat it, and they come in at $102. Well, the way the mechanism works is now provider system B is held to the $102 plus 5%. And so what's happening is that provider system B is performing better, and yet they're being penalized by being paid less in the future because we continue to anchor on that historical mark. And so what this encourages is that systems will say, oh, I see that $105 mark. I'm going to barely beat it. So I make a little money on this arrangement, so I look like I'm doing well, but I'm really not shooting myself in the foot for year 2, year 3, year 4. And so I think we really need to evaluate contracts and mechanisms for payment that are based solely on trend. We really need to be looking at benchmarks and where we want to be in the future, and then get that from plan A to plan B, a sort of spectrum. So next slide, please. I may be having a lag in my internet. Are you guys seeing the next slide on the 1-year time horizon?
Yes, we're seeing that.
Okay, great. So the next thing I want to talk about is that 1-year time horizon. So a lot of these contracts and arrangements are based on these 1-year measures, as I said. This is payment, this is quality measures, all sorts of things. And so what happens is that provider systems are constantly asking, well, what's my ROI? Why should I invest in XYZ care management program? Why should I invest on community outreach? Why should I invest in XYZ initiatives? And those questions, while they may be very altruistic and within the missions of those organizations, unfortunately, they do have to answer to the financials. They need to stay afloat, right? They need to stay open for those populations. And so the constant question of what is my ROI measured on a 1-year time horizon continues to come up and continues to impede long-term progress towards serving the population and improving care for everybody. I think this 1-year time horizon also encourages a lack of planning for years that are unpredictable, right? So because it's a 1-year time horizon, I'm always going to assume that next year is going to be a normal year. And so for insurance companies, they don't tend to behave this way. And insurance companies have been around 100 years, some of them. And so they manage things like reserves. Reserves meaning I have a bunch of money set aside for bad years. And if I happen to have a good year, I might be able to release those reserves, meaning I can take that money that I've set aside and say, oh, I've had a great year. I don't need to keep this much, right? Because I've had a great year. I'm going to let some of that go and let that premium costs go down for next year. And if I have a poor year, then I have this pot of money on the side that can help mitigate some of those high costs. So that's how insurance companies manage their finances. I don't see the same thing for provider organizations right now. I don't think that sophistication of financial management has kind of worked its way into that part of the system. And so I think we need to be encouraging that sort of thing. The other things on the slide that I've just pointed out are things that we all know just from the last couple of years that are crazy things that are happening, right? We have supply chain issues, people having trouble getting the things that they need. We have a situation now where medical inflation is actually above normal CPI, which is or under normal CPI, which is completely abnormal, right? Normally CPI, as we've experienced in decades, is very low, and then medical inflation is higher. We are actually flipped right now, which is very strange. And then, of course, all the pandemic and the mental trauma and everything that's going on, and we don't know the long-term impacts of all of that on folks, and we won't know, I think, for a very long time. People turning away care that they should be because they're afraid of catching COVID and all these other things. So next slide, please. I think this is actually my last slide, so hopefully I was brief enough. So the use of risk scoring. So risk scoring or risk adjustment is this mechanism that was invented to try to tag a value on every individual that says, how much will this person cost either this year or next year? There's two different kinds of risk scoring. But risk scores were developed algorithmically, mathematically, as a predictor of cost. They don't actually reflect somebody's need. So for example, a risk score for a woman who is currently pregnant is actually pretty high for the current year because we know she's going to have some claims this year, right? But next year, that risk score should come down. And that's the way a risk score works. It is based on cost, but it's not actually based on that person's health need. And so what happens, though, is that people are using this scoring mechanism sort of against its intentional purposes. So the intentional purposes was to predict cost, and people are using risk scores to allocate resources towards care management or pinpoint folks that need more outreach or things like that. It is also being used for payment purposes, and so as a provider system, if you've taken on risk for a population and that risk score for the people that you've gotten is artificially low because those people have not been going to the doctor because they've not been getting their preventative services, that risk score is going to be low because their history says that they don't use services. But the reality is that person, those people's health needs are actually high because they have not been using their preventative care and taking care of themselves for their chronic conditions and et cetera. And so there's this mismatch here of predicting costs and what people's actual health needs are. Now, I believe that a lot of risk scoring mechanisms, and there's a variety of them out there, are starting to incorporate SDOH. But I caution that SDOH measures often in these risk scoring mechanisms right now are based on proxies such as zip code, proxies based on race, proxies based on income level. And these, again, are proxies, right? So they don't actually say need. We're just trying to guess on, as an overall, what's the need of this zip code? But that doesn't actually get down to the individual level where if you're using this risk score to deploy some care management tools or aim interventions at specific people, it's not going to get there, right? Because then I'd be aiming at an entire zip code, not a specific person where we know something is truly needed for that person. So I think investments in the system using risk scoring should be deployed everywhere and not just to people who are covered under these alternative payment models. So often these risk scores are only used for a specific contract or a specific, value-based system. But what happens at a provider level is you don't actually treat somebody when they come in the door and say, oh, you're part of this contract, I'm going to do this differently, and you're part of this contract, I'm going to do this other thing. That doesn't quite happen. And so we need to encourage adoption of all these things across an entire population, not tied to just specifically that contract that you're in. So I think my time is up, so I will hand it back over. Thank you so much for having me.
Thank you. So our last listening session presenter is Ms. Shari Erickson, who is the Chief Advocacy Officer and Senior Vice President of Government Affairs and Public Policy at the American College of Physicians. Her organization submitted a proposal to PTAC jointly with the National Committee for Quality Assurance. Shari, please go ahead.
Thank you so much for having me, and I appreciate the opportunity to speak to the group. As was indicated, ACP submitted a model to the PTAC previously, and along with NCQA. Just as a little bit of background for those that aren't aware, American College of Physicians, we represent 161,000 internal medicine physicians across the country and internationally. We have members that are general internal medicine physicians, as well as those that are subspecialists in internal medicine as well. So that's why we were really interested in looking at models that could really involve both primary care as well as subspecialists in ways that hadn't really been introduced before. Our model ultimately, go to the next slide, please. Our model ultimately was recommended by the PTAC to HHS for a 5-year pilot to address and refine some of the issues that were raised through the review process. It was identified as meeting all the criterion that are specified by the Secretary for these models, and so we're hopeful that we can continue these discussions with CMMI and others that may try to move some of these aspects forward. Just as a reminder for those that may not be as familiar with the model, It includes sort of a process that first engages the patient with their physician in a collaborative manner to agree that a specialty referral is appropriate. That referral occurs to a specialty practice. In this process, though, the specialty practice pre-screens this referral and accompanying documentation to ensure that it is truly appropriate, so that we eliminate any potential additional challenges with regard to administrative burden, et cetera, for inappropriate referrals that may occur. The visit then with that specialty practice triggers an active phase of attribution for this model. And the specialty practice role may vary. They could be involved in co-managing the patient's treatment. They could be the primary manager or somewhere in between to ensure the most appropriate care for the patient. Next slide, please. So in the process of developing this model, and then also in terms of the overall input that ACP provides to CMS and other payers, et cetera, on value-based and total cost of care models, we've really identified a number of best practices from our perspective to truly help clinicians engage in these types of accountable care arrangements. And a big one, and this is, I think many of the things I will say now are reflective of things that you've already heard from the other presenters. The measures really need to be focused on a more limited set that are truly patient-centered, actionable, appropriately attributed, and evidence-based for these public reporting and payment purposes. But we also need to find mechanisms to support the use of clinically meaningful measures for internal quality improvement. Incentivizing the use of QI measures really will allow for greater innovation opportunities and engender trust, which I know came up earlier as well. There need to be some safe harbor opportunities for practices to engage in innovative types of approaches here. And we do need to move, and that will take some time to evolve us to that place. In the meantime, though, we could try to move toward measurement more at a practice level than at the individual clinician level. We at ACP have actually reviewed a number of internal medicine relevant measures for validity, and we recommend prioritizing the use of those, and also prioritizing the use of measures focused on prevention, things like cancer screening, tobacco, alcohol, and drug use screening, et cetera. The other thing that we've recommended strongly is that performance targets need to be provided to clinicians and clinical care teams in a prospective and transparent manner, and that this feedback be accurate, actionable, and timely, and appropriate to attribution and benchmarking are critical. Again, this came up earlier in the conversation. Voluntary patient attribution is really a gold standard. The patient relationship codes are one promising form of attribution, but absent these, we need robust case minimums that should be used. Additionally, benchmarks need to be fixed across all participants. Relative benchmarks, as we've seen, create really arbitrary winners and losers. And we need to use the most current data available, perhaps via shorter performance periods, to try to move this forward. Next slide, please. Other best practices that we've identified and that are really incorporated into our model are that the primary care and specialty care practices need to be able to work collaboratively to establish a patient care plan. It needs to be customized to account for individual patient and family circumstances and preferences. This leads to a more a mechanism to really truly have patients engaged in their care and be able to for lack of a better way to say it, be more sorry, I'm having some background noise, be more able to engage in their care in a way that actually helps move forward higher quality outcomes. Also, an additional piece of this are care coordination agreements between primary care and specialty care practices. It needs to be clear that all involved in the patient's care understand their role and expectations. And actually, we just recently put out, just last month, an updated policy around this that gets into some detail as to how this can occur, what some of the best practices can be around this, clarifying when the specialty clinician is acting as that patient's primary clinician, or if they agree to co-manage a patient's care. And there are a number of different critical elements and helpful elements, et cetera, that should be engaged in trying to do this. Communication and data sharing protocols need to be clearly established within these agreements. These are including mechanisms that ensure notifications are prioritized based on urgency. These are all things that can and should be established up front in order to ensure that these models are successful. We need clarity when the handoff needs to occur back to primary care. There are templates that can be put in place for these types of transitions of care that do account for patient preferences. And each practice should establish an internal plan within that practice that establishes and defines team members for each of the clinical and care coordination tasks. Next slide, please. So how do we encourage specialty engagement? There are a number of models that were spoken about earlier where we've had primary care clinicians involved in them. It's been a little bit more challenging, I think, to engage specialty care clinicians in a number of models. One of the issues is that these models really haven't been scalable to different types of specialties, and that's something that we've proposed through our medical neighborhood model is something that could occur, something that could be scalable, but also built on a fundamentally similar framework. This allows it to be understandable, predictable, et cetera, to the primary care and specialty practices. And communication and information sharing is critical. Specialty care clinician practice should be involved in pre-screening. I mentioned this earlier, all referrals and the accompanying documentation. And I discussed earlier the care coordination agreements. Reimbursement structure needs to be able to support specialty care engagement. And it also needs to, we also need to ensure that we're reducing unnecessary and duplicative work and administrative burden. This is why triaging those referrals and having that pre-screening is critically important. And total cost of care models need to incorporate incentives for patients to engage with those that are participating. Things like transportation, copay waivers, et cetera. Just innovative ideas that we could consider layering into these models. And total cost of care can be reviewed and aggregated in each practice as well as across both primary care and specialty care practices. Next slide, please. How do we operationalize this? And this is something that's laid out in that paper that I just mentioned that we released just about a month ago. It includes critical elements of the referral that need to be included. We need a prepared patient. That's, again, working together with the patient up front to ensure that they know what's happening and why. You need to have patient demographics and scheduling information. All kinds of special considerations for that patient should be and can be considered up front, including their language needs, any other cognitive needs that they may need to be addressed, caregiver assistance, et cetera. The referral information needs to clearly identify what the clinical question is. Why is this referral happening, and have the data associated with it? And we outlined some core data that should be incorporated in these referrals. And then the referral request needs to have referral tracking associated with it. Both the primary care and the specialty care practices, again, through care coordination agreements, can lay out how this occurs and ensure that the turnaround and the closing the loop happens. Next slide. And a response. So moving beyond the referral itself, and that's really what we delve into in our newer paper, is there needs to be a clear answer to the clinical question, or addressing the reason for the referral, and there needs to be agreement. And this is the type of thing that can be laid out through the care coordination agreements. What is the role of specialty care, both now and over the longer term, for this patient? We need to confirm new and existing or changed diagnoses that occur during the specialty practice visit, medication and equipment changes, also any testing that's occurred or additional procedures. And it needs to be clear what education was provided to the patient and what still is recommended moving forward. Are there any secondary referrals that occurred? And then can any recommended services or actions be done by the primary care or the patient-centered medical home that needs to occur following the specialty practice visit? Can you hit next slide? The other thing is there needs to be a clear indication of what the specialty care practice is going to do. What has the patient been instructed to do, and what the referring physician needs to do and when. This is critical to successful care coordination beyond the referral. And we need to find, easy to find and refer in the response note, all of these elements. Next slide. Moving on beyond this, and really something that could be layered into this type of a model, is integration with behavioral health, with primary care as well as with specialty care, if you think about it in the context of a model such as this. The collaborative care model is one model that allows patients to be seen by primary care and evaluated for behavioral health issues. in consultation with psychiatry and then be referred as needed. And that's a good start. But I'll say the challenge with this is that the implementation of a model like this in primary care is not fully supported today. The upfront cost to build the infrastructure to do this successfully is just simply not covered through the existing codes and payment mechanisms that are out there right now. So how can we consider integrating a model such as this with the medical neighborhood model, allowing even the specialty care practices to engage more fully in the care of patients and those with complex needs? Next slide, please. The other aspect I want to hit on, which came up earlier too in a couple of the presentations, is the need to address health equity and social drivers of health. One of the things that ACP has been calling for now and moving forward in particular is payers need to prioritize the inclusion of underserved patient populations in these models. We need to do this with every single model. It's just no way we can figure out how to do it if we don't do it now. We have to create validated ways to measure the cost of caring for these patients, and I believe this was spoken about earlier as well. Those that are experiencing healthcare disparities and inequities based on personal characteristics, and those who are disproportionately impacted by social drivers of health. How can we start to figure that out if we don't incorporate them into the models moving forward? And patients and practices and clinicians need to be incentivized to engage in innovative approaches to do this. There need to be safe harbors set aside perhaps for those practices that really are interested in taking on some innovative ways to help do this within their practice. And actually, I'll mention ACP has more policy on this coming soon. Actually, we have a paper being released in the next few weeks that will detail some additional ideas around this issue, but it's critically important that it be layered in moving forward to all models. Next slide. And I think that's it. I'm finished. So I just saw my note to wrap up as well. So perfect timing.
Great. Thank you. So thank you all so much for sharing your experiences with us today. You certainly helped us cover a lot of ground during this session. So now I'd like to open up the discussion to our committee members for questions. And just a reminder to turn your 10 cards up when you have comments and questions. Lee.
Sure. Thanks so much for those great presentations. I'm interested, Dr. Kendrick and Dr. Zimmerman, if y'all can comment on both the complexity of the metric universe and process and the critical nature of the timeliness of data reporting and financial accountability in a total cost of care environment.
Sure. Want me to start?
Absolutely.
I'll start quickly and then you add on. So in Medicare Advantage, CMS has done us a favor. They've actually predefined a set of quality measures that we're all working on. Interestingly, there's 40 plus measures that go into star ratings. We actually put about 10 to 15 in the physician contracts because those are the ones that we believe they can influence the most. Some of them are actually not star measures. Some of them are proxy measures like the access to care measure I mentioned, because we know, for instance, readmission rate is not credible, even at a medical group level, likely, depending on how many lives they have, and certainly not an individual physician level. But we know that if you follow up within 7 days, you will reduce readmissions by 63% in our study. So what do we incentivize physicians on? That follow-up. So we have those defined measures. Wonderful. They're, many of them are, NCQA, and we are very clear. Let's use standard measures wherever possible, proxies when we need to. But to your point about the timeliness, I can't influence a follow-up if I wait for a claim for a readmission. I can only do that if I know someone was discharged from the hospital. So the ADT feeds and partnering with HIEs is really critical so that we know, and we have a lot of health systems who say, well, we know all about our discharges. Well, yeah, if they're within your health system. 50% of your care for your attributed population, we know, occurs outside your system. So we need that. And I love the concept of a national HIE because patients travel, right? And so I love that idea. And then lastly, I'll talk about timeliness for cost of care. Using claims payment for cost of care, it is retrospective, it is delayed. I have lots of conversations with physicians to say, I understand, it's already happened, but let's look at what that trend tells us and let's identify opportunities. It is very, very valuable. Now, not to the risk adjustment issue, which I loved, about future care, but at least we can look at trends. Do we have an opportunity in inpatient, an outpatient? Do we have an opportunity to care for heart failure patients better? Do we have a Hispanic population that has a higher cost of care, a higher ED visit rate? Let's look at our opportunities. So that retrospective perspective, I think, is okay. We have a 2-month delay, we're pretty short delay. That's actually okay for that. But I need timely information to be able to act on it. That discharge, that ED visit. So I don't know if that answered your questions, but I'll turn it over.
Okay, great. Thanks. So I would make 3 quick points as well. The first one is in the current measurement approach and the data availability scenario, I think you've heard from all of the presenters about the workarounds that have to be put into place. The proxies in essence for social determinants and other things that most get stuck with. And so I'm in the business of making that data available in real time and then exercising or acting on that data, because of course the work we're doing is not some blob of 1,000 patients. It's literally 1 million decisions on 1,000 patients that happen every day that we're trying to influence. The most complex system you can imagine. And so having the row-level patient data on each of these domains of information are critical. It's just unfortunate that our current measurement approach doesn't get it done, and we need to be, I think, measuring patient-centric at the community-wide level across all sources. And in that vein, then one of the things we did while I was on the chair of the board at NCQA was to focus on shifting the concept from certifying and validating the measures themselves to certifying and validating the data set being used to do the measurement. Because if the data set can be certified to be complete of all sources of data on the patient's record and accurate, the code normalization, identity resolution can be good, then we can evolve our measurement approach to measure the right things, because as Dr. Zimmerman was indicating, you often have to find a proxy for 30-day readmission, some proxy activity someone can do, because there's no way to accurately measure it without the full community data. The last thing I would mention is the real-time or the more rapid availability of cost of care. I was a medical director at Archimedes, which was a California startup, where we did full-scale simulations of human physiology and anatomy and predictions of things. And one of the things I worked on there, we actually got a patent on, was using clinical data outputs to drive predictive cost. And so I really think that with the live clinical data, we could arrive at some conclusions and approaches that would allow us to see what the cost is probably going to be 6 months from now when we get the fully adjudicated claims coming back from different organizations, and that would be a really good directional indicator to provide very early on in the process for providers.
Great. Thank you. I think, Jen, you're next.
I too want to thank all of our presenters for excellent presentations and just so much valuable information. My question is for you, Dr. Kendrick. It is so impressive what you've been able to put into place. And I think there's a couple of things that we can learn from your experience that I'd like to ask about. You mentioned that in order to create this impressive system around data analytics that serves up real-time data at the point of care to help influence decisions and ultimately patient outcomes required 10 years of build and infrastructure. And I like the word that you used around dwell time, and that not only creating the infrastructure is important, but then letting the process work to actually actualize the outcomes. So this committee talks about that a lot around a couple of items, and I'd like you to comment on them. The first is around capital to build this infrastructure. It takes, there is risk in building the infrastructure with delayed opportunity to evaluate its performance. So my first question is, or a request is to hear a little bit more about capital investments. And then you mentioned, sadly, it sounds like the current payment model or infrastructure will be retiring with grants. And we also talk often about care model redesign, payment incentives, and then obviously the last factor is sustainability when we do see high quality outcomes. outcomes. So my other questions, what I'd like to hear more about is what's your sustainability plan?
Great questions. So let's see. So the last two slides that I did not get to, unfortunately, I took too long, indicated or would have shown you that there are 75 other organizations like MyHealth across the country that are already in existence. They're not all at the same level of sophistication, some more, some less. But suffice to say that the work at the community level within these states and regions has been done to build these governances. It covers about 290 to 310 million lives in this country already. So there's a substantial infrastructure there. And the good news is it's infrastructure. So it wasn't built specifically to be a research lab for CMMI. It was built because of the interoperability pressures that ONC faces and that the providers all face to meet meaningful use. And not just to check boxes in federal government programs, but we know to avoid making mistakes, to avoid prescribing things patients are allergic to, and doing the wrong procedure on the patient, and so on. And so that infrastructure has had a pretty steady, steady investment starting in 2009 with the American Relief and Recovery Act and the beginning of meaningful use. And even before that, as much as a decade or two before that, several communities around the country begun building that infrastructure. So I emphasize that this is like an interstate highway system, right? In fact, we use the term now, we're trying to get away from the term health information exchange because it makes it feel like a healthcare program. And we're starting to use the term health data utility to indicate that, look, this is like clean water or electricity. It's an essential component of every community. It just so happens that the work of CMMI could build on top of this, could really leverage these things, and that these are not unicorns. They exist in many places. And again, I will emphasize, it's that base of governance and trust that has to exist in order to build the technology on top. Technology is the easy part generally. And we've been blessed with great governance and collaboration across Oklahoma. Even when we had a state government that wasn't really engaged in making this happen, the community was able to pull it together. So that's the answer, I think, hopefully, to your first question. Happy to take a follow-up on it. And the second question was about, can you remind me, sorry?
Comments about sustainability.
Oh, yeah. So we always built, these organizations are generally nonprofits for a reason, right? It's tough to ask everybody, especially, say, tribal health systems, for their data with a profit motive on the back end. And so we build these as nonprofit organizations. And unfortunately, the major funding for meaningful use to sustain them and continue to grow them ended last October, a year ago. And so they're on their own now and into sustainability mode. MyHealth never really had access to those funds, but we were able to bootstrap and build thanks to CMMI models. And so, as you can see, we've sort of used, we think of CMMI models as the stepping stones we've used to expand our functionality, which is why it's even more acutely felt when we have to pull back on capabilities because the end of a model has arrived. There was an audible scream across Oklahoma when we had to delete all of the Medicare data from the CPC Plus and CPC programs because because of what I showed you that were great directional indicators of impact, we'll never be able to finish that research because we had to delete the data behind it. And really the health data utility is the only place you're going to have all the commercial claims and the Medicare claims together in one place to be able to analyze them. So in terms of sustainability, what we've done is say, look, we now have a shrink wrap product for social determinants of health screening, and we need to sign up about, in terms of lives, we think we can deliver that service to everybody in Oklahoma. We've already announced we want to be the first state to have border-to-border universal social determinants of health screening and intervention. We think we can deliver it for 25 cents a screening, which is remarkable when you think about the labor cost it would take just to do those individual screenings with a human. So we've put it on the marketplace in Oklahoma, and we're hoping that payers and health plans and programs sign up to take advantage of these services.
Great. Thanks so much. Jay.
Thank you. And again, great presentations by all our presenters. I have two questions for Dr. Zimmerman. My first one is I appreciate the cost savings from a fee-for-service comparison, but I'm curious, have you been able to sustain your trends year over year within your plan, either cost savings or reduced medical trends? And my second one is, what's your approach to your pharmaceutical cost management?
Okay. So we look at medical costs in multiple ways, and that was just one that was sort of an easy benchmark. But yes, we look at trend. Now, I hope you'll allow me to exclude 2020 and 2021, because as I say to my CEO, a pandemic is not really good for medical costs, right? Either we're under spending because people aren't getting the care they need, or we're overspending because people are sick. And so 2020, 2021, excluding those, we do look at our trend year over year, and we have had a significantly lower trend than the industry. So if the industry was at 4 or 5%, we were having a much lower trend, sometime in the 1 or 2%. Now, again, did not hold through 2021. So we're fingers crossed for 2022. So we do look at other data. The other thing that we've seen, and I'm going to get your name wrong, but Ling, you can speak to this too, right? We've seen different areas pop up in medical costs. Like, I'm old, Medicare beneficiary age. So, I remember when inpatient was the majority of the spending. Well, that's not the case anymore. It's significant, but that's not the case anymore. And we've seen pharmaceutical costs, which is why you're asking, I'm sure, increasing both in the medical spend, specialty spend, and in the ambulatory pharmacy. So we do see different things, increasing over time. And so we do look at all that trend. It isn't as simple as an overall trend. And then your question around pharmaceutical costs is, I will say, interestingly, we have a plan in California, and in California, physicians historically have not taken total cost of care. We think they're very, very advanced, but they take medical costs, but they don't take total cost of care to include pharmacy. And we think it's really important to do both, because, of course, it's important that people adhere to their pharmaceutical regimen in order to manage medical costs. So we do a couple things. Clearly, as a payer, we have our partner, our PBM, so we can work with them on preferred networks, on all sorts of things there. But we also work very hard to balance the pharmacy and the medical costs. So, for instance, a few years ago, we came out with a zero copay insulin benefit. Why? Because what our physicians told us was insulin was putting their beneficiaries into the coverage gap, and they weren't able to afford it, and it was really impacting their health and their overall cost of care. And so we invested and said, we need to take away that barrier. So we do think holistically about pharmacy costs. We do traditional prior auth and those sorts of things, but we also spend a lot of time on both technology and programs to increase med adherence. And then on the medical side, we work in areas, for instance, oncology or rheumatology. We work with those specialists and programs to improve the effectiveness of the care that we're providing there. Did that answer your questions?
Yes, thank you.
That's great. Thanks. Josh?
Great. Just one more echo for all the great presentations we heard. I actually have two questions for Dr. Zimmerman as well. Maybe I can separate them because the first one's a little bit long. But you showed some very impressive results in slide 2 and 5, and then I was struck by a word after that showed up in slide 6 and 8 around maturity. This idea that right out of the gate, giving full risk and then paying back to the payer is not what we want. And I think in principle that's true. And I'm wondering if you can kind of give us more detail around how you thought about maturity with respect to incentives for early behaviors for managing populations, contrast that with more mature or later incentives. What were the sizes of those? What were those behaviors? And then kind of related to that, I think you mentioned on slide 8 that their care management programs were structured in a way based on maturity. So again, how did you assess that maturity in the context of care management? And how did those supports change over time, kind of early versus late? Would love detail on that.
This has been a huge learning, right? So early on in the plan, our plan was started by a group of physicians who already were really good at managing total cost of care. They had the infrastructure, they had the data and analytics, they had the case management programs, and they were really good at it. And it's like, great, we'll just provide all the right data, all the right contracts, all the right, and we're good to go. Well, that has not been our experience. And so we have learned the hard way that it is not just, of the 6 drivers, it isn't just putting that in place, right? You actually have to understand what it is, what does it mean to deliver accountable care. So here's what we do early on, and it is a work in progress. I am not telling you we have it 100% right yet, because we just don't. So we're all learning, and I love this, hearing from each other, my mind sort of going a mile a minute. But so here's what we do around contracting. To put a group, so a couple things. One is you need an actuarially credible population. So if you're starting out in a new market and we're opening a new plan and a medical group only has 300 patients, it's not fair to put them at total cost of care risk. Ling, I'm assuming you'd agree with me. And I don't know what that number is. Our actuaries tell me it's about 1,500 to 2,000. I don't know if you'd agree with that, but something like that. You need that. So first of all, you have to be careful about the number of lives. Even if you have the number of lives, to put a group at total cost of care downside risk, I think is not responsible initially. What we do is we thought long and hard on those behaviors. Now I'm using Medicare Advantage as an example here, so I'll use those drivers. What do you need to do in year 1? Here's what you need to do. You only need to do a few things. You need to, number 1, make sure that you document the chronic conditions, right? You need to document the chronic conditions so that you get an accurate premium the next year, but you also need to know, we need to know who your diabetics are. We need to know who the diabetics are that have complications. Like, we can't manage the population without that, so we need to know that. Second is we've got certain quality metrics that for star rating, year 1 is the performance period. We've got to start working on those. Got to put in place that collaboration, that leadership, that shared performance, that accountability, those incentives, all of that in place. We've got to put that in place. And then it is about 2 things. Access to primary care. You got to see all your patients, and you got to see your sicker patients more. And in our model, we like our primary care physicians to see their patients at least as often as they see a specialist. It isn't that they don't need to see 5 specialists, but if they need to see 5 specialists, they need to see you just as much. So we do a PCP to specialist ratio, and we try to get that to about 1. Follow-up after discharge, add that access to care, call me first, educating the consumer, making sure that they understand your role as their primary care may be different than it was last year. Let's talk about what I'm going to do for you and what you're going to do as well. You have some accountability in this too, right? And then the 5th one for year 1 is around managing those highest risk patients. Like, let's start with those. Right? Let's know who they are, not necessarily just using a risk score. I agree with you, Ling. We have a methodology that looks, because there's a lot of people with very high risk score that we can't do anything about. Right? If you have a transplant, we can maximize our reinsurance and our contract, but we probably can't change the trajectory of your disease. Who is impactable? Who do we find that's impactable? Let's identify those people. Let's manage those. Let's put in place complex case management, end-of-life programs, transitions of care programs, those sorts of things. But that's it. Let's work on those things. Let's put those things in your contract, right? And then over time evolving. And that's come from a lot of learning. So maybe I answered both your questions.
Thanks, that's very helpful. My second is, I think, hopefully quick. We have raised this issue of kind of how alignment occurs down to the level of clinicians or clinical groups. And in one of your slides, you mentioned that the goal for physician compensation is 30 to 50% under value-based compensation. And I'm wondering if you can comment on maybe 2 pieces of that. One, those results that you showed, the impressive results, was that at that goal, or were you able to achieve those even short of it? And 2, have you found that the results track with the level of compensation, or is there a threshold that you're seeing that we would need to get to see those results?
Yeah. Now you're asking questions about human behavior, right? And what incentivizes human behavior. I think that we did see that those groups that had the 30 to 50% compensation performed better. But it was Is it because that's how I'm paid? Sure. It's also, think about it, and we've heard this from the other presenters, it's also where resources are devoted. It's also where information is shared, right? We're all working towards those. It's a priority for me, but it also is a priority for my organization. And so we're all working in the same way. I do like to say, though, that people, and physicians are people, are incentivized by a lot of things, and let's remember that. And, you like to be recognized for your good performance. This is a really, really quick story. I give an award among our 12 physician groups for the highest performance on clinical metrics. One year I gave, it was the year of a Winter Olympics. I gave medals, gold, silver, bronze. I bought a little step stool in, the gold team, the gold physician medical director stood up a little higher than the other two. Cost $35. That silver team said, we're going to get you next year. And they were number one the next year. And we're like, go ahead and compete. So don't forget that there are other things. We want to do a good job. Physicians, for instance, that work for a health system may think very differently about their goals in life than an independent physician group. So we want to model that compensation so it meets individual goals.
Thank you. As a human, a physician, and a behavioral scientist, I appreciate that.
Thank you. Walter?
I also wanted to just extend my gratitude to all the presenters, all very informative. It was really good. My question is also for Dr. Zimmerman. It strikes me that one of the important tools Essence and indeed all Medicare Advantage plans have at their disposal to achieve their results is that of a narrow provider network, one consisting of higher quality, lower cost providers achieved through contracting and credentialing. This is a tool that has historically been missing in CMMI value-based demonstration projects, as one of the key tenets of CMS has always been the preservation of provider choice for Medicare beneficiaries. My question is, how essential is a narrow network of providers to the success of the impressive outcomes from Essence and Lumeris you shared with us? And do you think it is possible for CMS to move to a world of value-based care without somehow limiting provider choice?
Yeah. Hi, Dr. Lin. It's a great question, and one that I think we are going to be able to answer because we are going into other markets with different products that will have larger networks. So ask me in a year or two and I'll have a real answer for you. Now it's a hypothetical. So I think that more than narrow, it's a definition of engaged. I think you can have a broad network if the physician organizations are actually engaged and committed to managing the population. And I will say in St. Louis, you know this very well, we actually have almost every health system in our network. And that's from a primary care perspective. Then from a specialty perspective, I think the same thing goes. If we have an engaged primary care, what we have found is we can have a very large network of specialists. We can even pay them a premium higher than market because they're going to see the more complex patients. They're not going to see the sort of less complex patients. So they may see fewer patients, but those that they see will be more appropriate. And we actually going to pay them a premium for caring for those patients and coordinating care with primary care. So I do think we can get there. Without it, I think those other levers are ones that we really need to think about, whether it be referrals, utilization management, ability to pay differently. I think without some of those levers, I think it will be difficult to achieve those savings. And then lastly, I'll say maybe we don't need to get 26% savings either. I think we'd all like to mitigate our trend and we'd love to see some downward, but we can all do this together and really help solve this problem for our country. So,
excellent.
Great, thanks. Larry?
Well, I'm going to split the questions around a little bit and not pick on Dr. Zimmerman anymore. I would like to ask Shari a question, and I have to preface this by saying I was one of the subject matter experts on the ACP document that you referenced. Most of what you talked about was structural, but have you done much work on the payment model associated with your recommendations?
Sure. Yeah. And so we really haven't had an opportunity to do so because there hasn't been an opportunity to implement it within the Innovation Center or with others at this point. So be very interested in doing more along those lines. And so, I think that that's something that it looks like maybe we can have somebody else who could comment on this as well, but we have not had an opportunity to do a lot more testing of it other than what's laid out in the detailed proposal.
Dr. Kendrick, did you have your hand up?
Yeah, I was just going to comment. I also participated early on in the development of this ACP model, and our experience on the ground was that what you're asking providers to do, especially in this triage event that the specialists might engage in, is really kind of a fee-for-service activity to get their attention to it. And we found that something on a level 2, kind of level 3. Payment would get the right level of attention to these consultations to get them dealt with, so that we could have a guaranteed dermatologist opinion within 48 hours, for example. And we did that across thousands of referrals. So just to give you some ballparks. Right.
And to add on to that, I would say we have continued discussions among our subspecialty societies to engage interest in doing some testing of the model. So there is interest out there along these lines, should we be able to move it forward.
Thank you.
Angelo?
Yeah, my question is again for Debbie. And so thinking back to your comments about the specialty care, particularly in more tertiary systems where the specialty care patients, such low percentages of those are actually at-risk patients. What are you doing and what have you seen in terms of being able to engage those specialists to really participate with a primary care doc around driving value?
Yeah, it's a great question. So as always, and I think you heard this from all the presenters today, we're trying hard to use our data to direct us as to where the opportunities are. And so, for instance, we find our Dr. Fusco, who's our medical director for utilization management, loves to say it's the 3 O's and the C's. It's cardiology, ophthalmology, oncology, and orthopedic surgery. And then we see a lot of dermatology. So we try to focus on where the opportunity is. Where is really the opportunity to educate and train? And it varies, but the majority of time we find that specialists are our best advocates here, who will meet with primary care physicians and say, look, when you're presented with this problem, here, let's develop, we can develop some clinical guidelines, or, here's how you care for this patient. Here's, try this first, use conservative therapy first. I don't really want to see them until you've done X, Y, Z, and educate them. And that conversation can happen. I do find a lot of, we've also been using data, episode grouper data, and then some other data around unnecessary care to identify opportunities with specialists. And to me, that data goes first to the specialists. It does not go to the primary care to try to change referral patterns. This goes to the specialist first. Number 1, to ensure that the data is credible. Number 2, we need everybody to get better. We will not solve this problem by saying, oh, we've got, 30% high performing, cardiologists, we're going to send everybody there. That's not going to help. We have to get everybody to improve. So to me, that data goes to the specialists. The specialists vet it, the specialists identify opportunities. They work together to improve the care, both within their subspecialty as well as the way they interact with primary care.
Great. We have about 2 minutes left. I have one question for Ying-Lin around benchmarking. I thought you had a lot of interesting comments related to the challenges of using historical benchmarks, and just curious your thoughts on alternative ways of calculating benchmarks, and how do you take into account improvement over time that's likely to occur for those who are in a value-based arrangement?
Yeah, I think don't get me wrong, right? Historical data is very important for giving a frame of reference, but I think there's an over-reliance on it, was my point. And so for benchmarking purposes, we want to look at where you're at, and we want to look at where we think you can be, maybe the best performing provider systems in the country, looking at specific measures to say what are the desirable readmission rates, what are the desirable things like that, and build a path between the two. And so I don't think that always anchoring to the past or to your immediate results or the results of your neighbors is always the best. Let's try to find what the ideal state is, where we are currently at, and build that bridge between.
Great, thank you. So at this time, I want to thank again our panel and all of our speakers, just terrific presentations. I think we could keep this discussion going much longer, but we need to take a break, which we are taking now until 1 p.m. Eastern Time. So please join us then. We have a great lineup of guests for our second listening session of the day on assessing best practices in care delivery for population-based total cost of care models. Thank you.
Produced by the U.S. Department of Health and Human Services.